Well, while you're finding that, I'm just gonna did you? Oh, now it's recorded. Okay, then I don't need to.
Okay, so so over to you guys. Any questions? Any thoughts? Have you been having success in some of your practice with your strips, with the workbook, with being able to work through some of them? Any confusion still?
I thought I was doing well and had the hang of it. And then we had the sim assignment where everything was fast forward and I realized, oh no, I don't know anything.
Okay, so one of the things I would say is in that sim assignment, it is like, I think it counts down. Does it count down 5, 4, 3, 2, 1? The expectation is that Leslie and I can do that. 5, 4, 3, 2, 1, I've got it. And even there's a risk of an error. I remember one time thinking something was an SVT, but it actually was a VTAC. Because unless you've taken a good look, and particularly sometimes even on a 12-lead ECG, that can be a real recording if it's a little bit of a narrower VTAC. And the patient was conscious still. So that was interesting, not good on my part. The expectation is not that you can do it in 5 seconds. The expectation is that you guys are going to use that systematic approach. And in that systematic approach, you're going to be able to work through P to P, R to R, the PR like, are they regular? What's the PR interval? What's the QRS? Look, everybody, make sure you look at your ST segment. What are we looking at the ST segment for? Sorry. What are we looking at the ST segment for?
Maybe a depression or elevation.
Yeah.
Yes. Okay, I'm sorry, guys. Just 1 second.
So that is correct. And Jennifer, remember that we said that it gets a little bit muddy before it gets clearer. So I think you're in exactly the right spot. So again, that is a good. You'll get it. Just
right.
Use that systematic approach, and as Janelle said, ST elevation or ST depression. That's what you're assessing.
And I'm just going to bring us to that for 1 second. Elevation means what? So elevation, we'd see it. Remember, we always look at that isoelectric line, right? We're always making sure we've got that isoelectric line in mind. And if we see that ST segment above the isoelectric line, so we're not coming back down and staying at the isoelectric line before we get to the T wave, then we're looking at damage. So elevation, we're thinking damage as in a myocardial infarction, where we actually see some damage. And Leslie, you can jump in if you want to clarify in a different way. ST depression means that that ST segment is below that isoelectric line. And typically when we're seeing ST depression, we're thinking ischemia. And we think of ischemia in the as something hopefully that can be reversible, application of oxygen, potentially provision of medications and other things. So ST depression is more likely something we're going to see with angina.
Sue, can I just jump in for one quick second here? And and maybe this is not the place to put it, and you can stop me. But look, even though you're looking at one strip in lead 2, to really make those diagnoses or those diagnoses that it is a myocardial infarction, you have to look at the 12-lead ECG and look at multiple areas. So while the lead 2 gives you indication that there's something going on, you would need the 12-lead to really look at it, the whole heart.
That is, and has everyone got that point? So when we're looking at lead 2, we're looking at one angle. We're looking at that electrical current from one angle. When we do a 12-lead ECG, we get to look at it from all those different angles, and that enables us to really get a clear picture and validation if there is something going on. Because to make the diagnosis of an MI, we actually want to see that ST elevation in more than one lead. Okay, just in more than one lead. And that's really important. But in this course, we're not asking you to read 12-lead ECGs. The week after the test, I'm just going to record a mini lecture. It's not going to be on this test, just about how when you see a 12-lead ECG, to know the patterns. So which are the 3 leads that tell you about an inferior view? which are the lead patterns that tell you about an anterior view. Knowing those patterns is really important. And there's certain characteristics about the different views, what you would expect from the morphology or the shape of those complexes from a different, you don't need this for the test, but just so you know, it's not, I don't want you to have deep knowledge of that, because that in itself is another 4 weeks to really understand interpreting a 12 lead ECG, but getting through cardiac monitoring in terms of reading lead 2 on a strip is going to be really helpful. So we got as far as looking at that ST segment. Remember, if we see elevation where our concern is potentially damage and potentially MI. If we see depression, typically we may think, is there ischemia, and is this something like angina where there's decreased oxygen to a portion of the heart? And then we look at T wave. And again, when we're looking at T waves, what do T waves tell us about? I know you guys know this. What does a T wave tell us?
Repolarization of the ventricles?
Yes, repolarization of the ventricles. And it's interesting that that's the place where we're likely to see if there is some damage occurring within the heart muscle, because that's a point of clarity around the repolarization. When there's damage, that that process is impacted. And so when we see that, we may see ST segment elevated, and we may also see that elevation of that T wave. And often Leslie and I would talk about those tombstones. Have you ever heard, you've heard that expression, I think in Leslie's class, or even in this course, those big tombstone T waves. Hopefully you don't see those. Those are often characteristically indicative of a high degree of damage. Any thoughts on that, Leslie?
So Ashley's asked, for this next test, if we observe ST depression, would it be appropriate to note something like this may indicate ischemia, or we're not saying it, but just making an observation?
Oh, no, it's excellent. That's such a great question. Yes, yes, yes. Here is the thing about nursing. We're always calling it, right? So we're calling it, we would say ST depression in lead 2, potential ischemia, immediate 12 lead. Everybody with me on that? ST depression, we would always call it ST depression or ST elevation, immediate 12 lead. We don't need an order for a 12 lead. So I don't know if there's any hospital policy anywhere in the world that says you need an order. Do a 12 lead, get a 12 lead done. No one is ever going to thank you. Thank you for not wasting resources and doing a 12 lead when the patient is potentially having an MI. So you should be able, if you're in a step down, if you're somewhere where a patient is on telemetry, you should be able to get that 12 lead ECG. Leslie, tell me if I am incorrect, because I always want.
No. So I think that because it is a diagnostic procedure, and I think that looking like you do a blood pressure, you don't need an order.
Right.
But some areas that we will be covered by medical directive. So if you're on medicine telemetry, the expectation is if you see that, you go ahead with the 12 lead.
Yeah, and I don't know anywhere where the patient is on a monitor where that wouldn't be the requirement.
Mm-hmm.
So maybe on ophthalmology, that's not the requirement, but the patient then is also not on a cardiac monitor.
Mm-hmm. Mm-hmm.
Okay,
good point.
So absolutely, you would note it, you would get the 12 lead, you're doing a rapid assessment. When we're working in high acuity, and I put this in my notes around test number 1, it is very rare that you're going to say I'm doing a head to toe. Because when I'm noting something that relates to a high acuity situation, a change potentially in patient condition, we're doing a focused assessment. A couple of points about that. When I do a cardiac assessment, it's never separate from a respiratory assessment. Respiratory assessment is never separate from cardiac. Because those two systems are so intertwined, cardiorespiratory assessment really requires both, and they happen fast. Right? They happen fast. Because when you're saying I'm doing a head to toe, you're checking someone's neuro reflexes, you're checking their hearing stuff, you're checking like all, things that all of their reflexes, but you're not doing that it's almost really, even when you go in to see a patient and you do a head to toe, you're somewhat selective in what you're doing. You need to know how to do a head to toe so that you can be effectively selective. And again, I don't know if I'm saying anything that is shocking or breaking anyone's rules, but it's so important that you're able to do that.
Sue?
Yes.
Yes. This might be a silly question, but is there like a common rhythm that you see like an ischemia or infarction in?
Oh, you know what? That is not a silly question. That's a fantastic question. Now you can see, it's interesting because some rhythms are more likely to lead to ischemia and some rhythms are more likely to potentially result from ischemia. And it all may depend on where you see. So somebody might have been in a sinus rhythm at home, then they had an MI. Now they come in and we see them, let's say in the ER, or they've gone up to the ICU and they have a lot of aberrant, so unusual beats coming from different places in the heart. You tend to have that excitability impacted. Depending on where in the heart you're impacted, you may see different kinds of rhythms. Do you remember that the normal automaticity starts in the SA node? And so if your MI is affecting that part of the heart, you may see that you've got aberrant beats and or a rhythm that starts lower in the heart. Leslie, your thoughts? Brad is often a common rhythm.
I agree. You would see it as a result of some other ailment or some other conditions, such as coming in with a myocardial infarction, and quite often they will have a lot of arrhythmias after an MI, and that in fact is one of the most common complications. Or because of the rhythm being either bradycardia or such as a very fast rhythm, they can infarct because of that.
Yeah, and in particular, so again, this is a really interesting point. And tell me, if you need me to repeat something, like Leslie said something that's so interesting to me, and now I want to carry it on. If it becomes too fast to follow, tell me to stop and I'm going to repeat it. But let's say, do you remember we studied some of those atrial rhythms that are very fast, right? There was some, like you had, and even sinus rhythms, sinus tachycardia, which can go very fast, up to 150. I personally have not seen it at 150. A sinus tachycardia, I've seen atrial rhythms, but let's say you have a sinus or an atrial rhythm, yeah, supraventricular tachycardia, you can have that at 180 easily, an SVT racing along at 180. Do you remember one of the consequences of having that rapid heartbeat? Remember, it's it normally should beat 60 to 100, beating like crazy. What is the consequence for the heart of that beating like crazy? When does the heart get its nourishment? Does anyone remember? This is really important, I think, for me to understand.
The lack of diastole
Yes.
heart.
Right, and somebody's answering, Emma's answering too. In the diastole, in the period of rest, is the only time when the heart gets its own nourishment. So if I'm beating at 60 beats per minute, you see how I have a nice gap there and I get my own, in the period of rest, I get my own nourishment. Now imagine if I'm beating at 180, I can't even do it. Where is there time for me to get my own nourishment? And nourishment comes in the form of that oxygen. So not only is there a greater oxygen demand because the heart is running a marathon here, right? But also there is less opportunity to get that nourishment through oxygen. And so very fast rhythms can often lead to consequences beyond the rhythm itself. And that one of those is an MI. And I have seen that myself. Leslie, I'm not sure if you've ever seen patients in a very fast rhythm and they're not, yes, and they're not able to tolerate, and that moves into an MI. And it's not that sometimes they're in a fast rhythm with an MI emerging, and sometimes in a fast rhythm, it's hard to see it. I'm not expecting you to be experts. I'm expecting you to be novice level interpreters using a systematic approach. Something is off or funny, even if you don't know what it is, just write down something's not right. Even that is better than nothing, okay? If you're not sure, even if it is right, then I say, no, it is right. I want you to say something's not right, because that's a good starting point. Leslie and I still see strips where we have to go, like what's going on here, and tease it out a little bit, okay? So be confident in using that systematic approach and then trying to figure it out. So I've actually seen patients who go from an SVT so fast and not compensating well for it, and actually infarct and go into a sudden deadly bradycardia. And so it can be, it depends on lots of things, but you can see it in all rhythms, and you're going to go through that systematic approach.
So we, Sue, aren't going to have to know, like in the simulation, the one that I did, I think it was number 4, we're not going to have to know that like the progression is going to be like NSR with PVC to like V-Fib to then V-TAC. Like, is that a common sequence, or is that just based on the patient?
Yeah. Right, just based on the patient, just go with the strip.
Okay.
So definitely don't try to, and remember I said, don't try to memorize things, right? I'm hopefully going to give you enough information. You're going to respond based on what you see, always using that systematic approach, because every patient's different, right? Everything is different, but you're just going to look every time. You're going to look at your P waves. Are they regular, spaced evenly? You're going to look at your QRS, right? And you measure from that top of that upper peak, R to R, R to R, R to R. Are they, can we call this a regular rhythm? Then we look at the rate. You know how to do your rate. You can, if it's a regular strip, you can use a variety of methods. If it's irregular, the only one you use is what? If it's regular, we have 3 methods. We have the 6-second strip. We have the sequence method, the counting method, which is the one that I typically use. And we have the the box method, right? Dividing by
300.
Yeah.
Or 1500 with the small boxes.
Yes. I don't know anyone who does that method, but if you like that method, go ahead. Leslie, do you know anyone who does that dividing method? No, but no. Legitimate. That's if the strip is regular. That's why you have to do the R to R and the P to P first. If the strip is irregular, just because I count the distance between 2 complexes, it doesn't mean that the distance between the next 2 complexes is the same, right? So I can't do anything that involves just counting between 2 complexes. If it's irregular, I have to do a 6-second strip. And for a 6-second strip, how do you know if a strip is 6 seconds?
30 boxes.
Mm-hmm. Or you see those little notches, right? It's between a starting notch to a 3-second notch to a 6-second notch. So those notches come every 3 seconds. And if you see the notch, trust the notch, right? If you see it, trust it. There's no tricking you here. You don't have to count those boxes. If you don't see a notch, then count the boxes. In practice, you'll always see that little notch. Is it, okay. So we did P to P, R to R. We want to make sure there's a P precedes every QRS. Now we've done the rate. Now we're going to measure some complexes and intervals. We're going to measure the PR interval. And do you remember that's the beginning of the P to where?
Is it to where the Q is?
Mm-hmm. And there's not a Q, right, to the QRS complex. The beginning, either negative deflection or upward deflection, either way. So we measure the PR interval, and you guys know that the expected normal range would be 0.12 to 0.20, 3 to 5 boxes, right? Then you're going to measure your QRS. The QRS is from the first deflection off that isoelectric line, up or down. And you're going to measure from the first deflection up or down until that wave comes back to that isoelectric line. And to be fair, sometimes it's a little hard to tell exactly the point where it comes up or down, like where you move from that QRS into the ST segment. Sometimes it's just, you sort of see a little notch move. It's not always perfect, right? It's not always perfect. And that's why for all of these measurements, there is a little bit of room, a little bit of leeway. Right, so don't agonize over half a box. But the normal QRS is typically, you'll see it either less than 0.12, which is 3 boxes, and some sources will say less than 0.11. Okay, either way, it doesn't matter. 0.11, 0.12, all the same, right? It's all the same. So less than 3 little boxes, but there is always some There's always some room. So if you said it's 0.12 or you said it's 0.10, all the same to me. Okay? Then you're looking, you're not measuring beyond this. You're looking at that ST segment. We already talked about that. And you're looking at that T wave. And then if there's aberrant beats, right? So that's in the recurring beats. Those are your recurring beats. And then you're going to name it. You're going to call it, right? What is that rhythm? And in order to do that, you have to look and say, do all the beats look at the same, or is there an aberrant beat? Is there something different in there? And so you saw on your lectures that you can have premature beats that come either from the atria or premature beats that come from the ventricle, right? So premature atrial contraction, PAC, premature ventricular contraction, PVC. And if it comes in a pattern, we talked about that. So if every other beat is a premature beat from the atrium, it would be called, let's say it could be called sinus rhythm with PACs in bigeminy or atrial bigeminy, or ventricular bigeminy if those beats are every other one. That's in, you've got that in your lecture, but just to recognize you're going to have to identify if there are aberrant beats coming from any other site. Any thoughts, Leslie?
No, I think that, and to me, it always is, how is it affecting the patient? So if there is a beat, every second beat, what is it doing to the cardiac output? So that's what I always think about.
How is, and also, and yeah, so, and I'll give an example. And tell me, is this helping you guys or not? Like, I don't know if I'm just talking to my, yeah. So a really good example following from what Leslie said, if every other beat is a premature ventricular contraction, so I don't have the atrial contraction happening there, what is the special thing that I get from my atrial contraction? We know there's passive into the ventricle, but what am I losing if I don't have an atrial contraction before that ventricular contraction?
The atrial kick, like the 30%.
Right. 30%, that's a lot, right? That's a lot of that cardiac output, that absolute emptying of the atrium. So if I saw every other beat is a premature ventricular contraction, I would think, wow, every other beat is losing 30% of cardiac output for that beat. But also my next thought is, and what might this lead to? Because if I'm having a fair number of ventricular contractions that are happening, would I be concerned that those beats may become the dominant ones? So could this lead to something else? Do you see that? And you don't have to know the answer, but you have to, your thinking will tell me. Even if you say, I'm not sure, this looks problematic because I'm losing atrial kick and losing cardiac output and also, you know, whatever. So you're always thinking, what could happen next? How is this a problem or not a problem for the patient? Okay. One of the things I was going to ask, and I know Amanda, you mentioned it, when you did those mega codes, did you like those mega codes?
Yeah, I'm gonna go with what Jen said. Like at first it was like, oh my God, this is going so fast. But then I watched it a second time and it was like way less overwhelming. So I was able to like actually look at the rhythm and not just like look at like the countdown and think, okay, I don't know what this is. But I watched it a second time and it was actually really helpful.
And I hope it's a little fun too, because you get the sense of that's how fast these things may be going, right? You can slow it down, you can watch it 10 times, you can, and so I think all of those mega codes were all valuable in different ways. They were really valuable in different ways because they showed lots of different things that you can look at.
Yeah, I only did the one so far, but I'm definitely going to go look at the other ones before the next test, just because I found it really helpful, and I'll probably like slow it down, like the playback speed. So
yeah, I think if you can, that's great. And just when you're not doing it like feeling like a test, but just I would say the first time around, immerse yourself just as an observer, tick, 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 and then go back again. Now I know what's going to happen. Let's slow this down and watch the sequence of events and how this is important. So for when you're able to identify all of these different kinds of rhythms, always using that systematic approach, the next step is, what do I do? So let's say I see a rhythm that looks like it may be, I don't know, a rapid rhythm. So I've got something that I think might be an SVT. What would I do?
I think when you have the really fast rhythms, the first thing you wanted to do was try to slow them down with different, I think the main thing you guys discussed was your vagal stimulations, or trying to slow down that beat so it can be interpreted.
Right. So first of all, it is so important that we try to take action, and we always go from the minimal action to the most relevant. Like, so most likely at success with minimal intervention, right? So we'll talk about that. But even before I get to intervention, am I going to do anything else? So I've got somebody, they come in, they say they're short of breath and they feel like there's butterflies in their chest. And I put them on a monitor and I see a rapid rhythm. And I think that rhythm is an SVT at 175. What else do I need to do? What else do I need to know? Somebody said, 10:02. Leslie has the most fastic, most phenomenal little cue. You know, Leslie, your O.
Oh my. So whenever you see a rhythm that's sort of alarming, you go, oh my, oxygen, monitor, and IV. You have to make sure you've got those in place. Okay, oxygen, monitor, IV. Oh my. And it's critical, first of all, and as Jen said, oxygen. All of these rhythms have the potential to increase cardiac oxygen demand. So even, I think I saw on one of the mega codes, even somebody had an O2 sat of 95 and they said they don't need oxygen. I don't live in that world. I'm not going to test you on that, like something like that, because I would always apply oxygen. At some point, you're going to get into your own practice. You're going to be superstar, ICU nurses or ER nurses. You're going to come back and have coffee with me, and you may have a different approach. Here is my approach. Always oxygen. Always oxygen. I want, unless there's a reason not to provide oxygen, right? A specific reason. Until we know more, we're always providing oxygen. Leslie, your thoughts on that? So yes, I'm going to back it up, and maybe I just sort of zoned out here for a moment. And I just wanted to remind everyone that when we always do our assessment. And so the first thing you want to do is ask yourself, is this patient stable or unstable?
Mm-hmm.
They can have a very fast rhythm and be stable, which gives you a little bit of breathing room.
Mm-hmm.
Or they can have a very fast rhythm and be totally unstable, which means you have to react very quickly. And so just as Sue said, oh my, so yes, I've taken the heart rate and I can't even count it because it's well over 180. If I could even count that fast, knowing that it says I need to get an IV, oxygen, and a monitor on this patient. And I agree, Sue. I teach ACLS, and the ACLS algorithm, which is like a worldwide consensus, says that if the SAT is over 94%, you don't need to worry about oxygen. But I, like Sue, believe in the moment, I need to figure out what's going on. I don't want to worry about that. So I put oxygen on until we can stabilize this patient and figure it all out. Yes, absolutely correct. You don't need oxygen because if you think of the oxygen dissociation curve and all of that, but in the heat of the moment, I just need to cross that off so I can work on other things lower in the algorithm. So I totally agree, Sue. Put on oxygen until you can figure out what's going on with this patient. And the oxygen, I definitely would agree with that.
Okay, so we're doing our oh my.
Sorry, I have a question.
Yep. Hi, Janelle.
So when you were to put on the oxygen, how much liters would you start with?
Like, again, do you remember we're talking about that titration to response, just the way we would titrate meds to response. If somebody had an O2 sat of 95 and they're in an SVT, I'm going to put on prongs at a couple of liters. So again, I'm going to see what happens. If they're already at 100%, I don't need to blow their oxygen out of the, they don't need to have a PaO2 of 165. So probably I'd put on a couple of liters, probably just prongs, because they're still satting well, but I don't know what's coming, right? I don't know what's coming, and that's why I'm with Leslie. I'm going to go to the oxygenation while we can, and so I don't have to think of it. I'm not, when a patient is crashing, I don't want to be looking for my nasal prongs or looking for my other kinds of equipment. Let's do what we can when we can. So just a couple of liters. Now that's not the 2 liter rule. It's always a bugaboo for me. There's no magic about 2 liters. I'm titrating to response, just titrating to response.
I also have a question, sorry. I don't know if this is relevant, but obviously we're focusing like on cardiac, but like you said, cardiac and respiratory are obviously tied. What if that patient is a COPD patient? Am I still going to put them on that? Because
always a tricky one. So I'm going to tell you for the NCLEX, you're not. And even for the NCLEX, sorry, for the NCLEX, it might be O2 sat above 95. You don't need oxygen. I just want you to be, so here's where I want to differentiate like real world and practice wisdom from Leslie and I and ACLS. So above 95, a COPDer is, and again, if I don't have gases and I don't know if they're a retainer, a CO2 retainer, remember we talked about that, there's all COPDers are not the same. I'm not going to make it that complex for you, but in the real world, I would say I would have the prongs there. I probably would put on a liter or two unless I know something different, but I'd have them there. Is that okay?
Yep.
I'm not gonna muddy it so much for you because you've got enough to think about.
I know. I was just wondering because that's obviously like perfect world nursing versus like reality. Right. So, and again, I'm just gonna say you're gonna go into practice, and the things that we talk about today, I hope they're different. Even in 18 months when you're practicing, you know why? That will show progress. I hope that they're saying a whole bunch of new things, because as we go to new things, what it shows is new evidence, and that means health moving forward. And so what I can talk about is my entire career. I have never seen a cardiologist come in and say, that man's O2 sat is 97. He doesn't need those prongs on, right? I've never seen a cardiologist not say, why don't we have some oxygen on this person who's got a SVT at 180? Because it is, again, support for the NCLEX. We're going to follow, I think, on that ACLS algorithm, which says O2 sat 94 and above, you're fine, right, Leslie?
Yes, yeah, correct. And that is, but I totally agree. And that in the heat of the moment, you have an unstable patient that has potential to deteriorate, go on to infarct. And so to put on oxygen, plus the fact, what happens when a CO2 retainer has oxygen on? What is going to happen? They're going to stop. They're going to stop breathing, and you're right there. So in the moments that you've got the oxygen on, this is an unstable patient, and I think that's what you see in emerge, don't you, Sue? Unless they're well documented and they come in all the time and they know that, they're putting oxygen on until they get it all sorted out. I've never seen anybody stop breathing because of a CO2 retainer that has come in an emergency and we put oxygen on them.
No, I have seen them have to be intubated. And then later the discussion about, did we give too much oxygen? Could we have, whatever, but that's all a coffee talk after the fact, because in the moment you're trying to save their life and you're really balancing a whole bunch of things. So just so you know, I know there's a temptation, and I got this, I think, from many of you who did that, label the order, the sequence of things you would do with the anaphylaxis. We don't live in a world where there's a perfect 1 to 10. We don't live in a world where there's a perfect, okay, this happens and then that happens. We live in a world where we can focus on what are the principles? What are the principles that I'm following? And what is the next best decision that comes from them? And does it make sense? Is that, and that's a harder world. And if we don't teach you that, we're not preparing you for real world nursing. If we teach you that every situation is simple, and then here's the simple answer, we're not preparing you even for the first day you're going to be in practice. Because judgment, that clinical judgment, comes into so much. And even Leslie and I, both of us looking after the same patient, might slightly deviate in how we approach things. But both of us are principle-based, understanding what is the situation, what is understanding what's happening beneath it. So I don't have a rule book about how I respond to things. I'm always thinking, as Leslie says, how is this impacting cardiac output? What's happening now? And what could this lead to? And both of us then respond to that within the realm of what we know are possible options. Okay, so let's get back to so we see this person, they're in a rapid SVT. We're able to say that. We do our, oh my, oxygen, monitor, and intravenous, right? Oxygen, monitor, intravenous. Those are actions that I'm taking, and they come all together, oh my. And then, but before we get to actions, are there any assessments that we need to do? Outside of a head to toe, because we're not checking someone's ears right now. What other assessments might I undertake? Cardiorespiratory, absolutely. When I'm doing my cardiorespiratory, and it's going to be quick, right? Quick, quick, quick. Am I asking you to listen for aberrant sounds, right? Like, so everybody can hear S1, S2. But am I asking you to listen for murmurs and all that kind of stuff? Yeah, Ashley, no, I'm absolutely not. And I'm going to just tell you a secret. Leslie will be much better than me at listening for clicks and murmurs and all kinds of things. You know why? It's a hallmark of her career to have learned to listen for those very well. I'm not saying I'm off the hook, and I do need to know those, but I am saying that an emergency nurse is much less likely to be doing that in depth and have had years and years, because I'm also looking after people having ectopic pregnancies and fractured hips and all kinds of things. This is what Leslie does. This is what is happening in the ICU. So when you're doing that cardiorespiratory assessment, you're not taking like 3 minutes trying to listen. Is there a murmur here? Am I hearing something unusual here? Does that make?
We can hear the dog. Is that Muffin's growling?
Muffin growling. My mom's PSW.
Yeah.
I apologize. I'm gonna go on.
Yeah.
Sorry.
Yes, go ahead. So one of the things I want to back this up to as well, folks, is that you see this fast rhythm, and now you've determined you need to do your ABC assessment, first of all, to help guide you. You're going to do your cardiorespiratory assessment, which in the heat of the moment might just mean vital signs. I want to know if this patient is unstable. When I have to talk about unstable patients, I'm thinking about alteration level consciousness, chest pain, shortness of breath, and decreased blood pressure. Those are the hallmarks of an unstable patient. So those are the things I'm looking for. So when you say, I'm going to assess for stability, or I'm going to assess the vital signs, so you've got this very fast rhythm, you've assessed their ABCs, and assessing that they are stable or unstable. And let's just say they're unstable. We always treat an unstable patient electrically, whatever that looks like. If they're too fast or too slow, we always treat them electrically. Now, just as an aside, it's outside the scope of an RN's practice to application of energy, but that means that we have things ready. So what do you think would be the appropriate treatment for a very fast rhythm? The blood pressure is 70 on 40, heart rate is 210, respiratory rate is 26. So blood pressure is 70 on 40, heart rate 210, respiratory rate is 26, and you've got oxygen on at nasal prongs, and so the stats are 95%. So Jennifer has already said, do a vasovagal. How do you do a vasovagal? Just shout it out.
That's the one where you can, one of them's like you try to get them to bear down like they're on the toilet.
That's exactly it. So you're going to get them to bear down. Nurses can do that. So as I see my rhythm tacking along there, as I'm calling for my the cardiologist or some physician support or nurse practitioner, I'm going to say, just bear down. Do not let any, and this is, so we do not let any of our residents actually do carotid sinus massage. And that is up to you're at the bedside, you're watching this going on. So it's up to you as well. So it's not just up to the resident to know not to do it, but we have to protect that patient as well. And so we'll say, no, we'll get them to bear down. We're not going to do carotid sinus massage. And so they bear down. And there's some fancy ways that Sue can talk about in Emerge, how they do this with syringes and all this kind of stuff. They do that now. They have like syringes, they blow into a closed syringe and all that. I just get them to bear down, pretend you're having a bowel movement, tense up your muscles and bear down. And that should be enough to cause the vagus nerve to take over and slow everything down. Sometimes it works, sometimes it doesn't. Sue, you're on mute.
I'm going to make a quick point about this. Many of our students work in long-term care, particularly bridgers or some of our collabs. Has anybody ever had a patient, even in the hospital, who's fainted on the toilet? It's very unlikely you'll go through the first couple of years of your practice without having a patient faint on the toilet. That's that vagal response, right? So that is where you're as you bear down, you activate that vagal nerve.
Yes, exactly.
Okay.
Go ahead.
I'm just going to come back though to that point. It's interesting. So the first question Leslie asked you to consider, so we've got our strip and we've taken our vitals, and the patient is unstable. And there's a real difference between a patient who's stable and unstable. And so for example, if I have this person who has a heart rate of 200 and a blood pressure of 110 on 80, I'm thinking I have a lot more time to respond. And so we have a lot more time to take action that is this sort of minimalist action that hopefully can help us before we move to more intensive treatments, right? So I would start with vagal maneuvers. We're not doing carotid sinus massage. That's an old thing. You may see it on TV and stuff. Yeah, like on Star Trek, I think that's what Spock used to do with his little move. But we're not doing that, right? We're doing vagal maneuvers, very effective, sometimes very ineffective. If a patient has very ineffective. If a patient has a blood pressure of 70/40, I may be doing that for 1 second while I'm waiting for somebody to come in. But as Leslie says, when a patient is unstable, we're moving very rapidly to what? What did she say?
I don't think we got to, oh, yes.
Unstable patient.
Is that the synchronized cardio something? I can't remember the full name. Where you basically try to shock them back into a regular rhythm.
So unstable patient, I want you just to like sear this in your brain, okay? Because it is a little bit of a that is an evolution, Leslie, that we have moved more to this, right? Particularly for, I think, those like rapid rhythms. Unstable rhythm, or patient unstable, rapid application of electricity.
Stuart, I just want to make the point that because the application of energy is not within the scope of a nurse's practice, however, we can get the pads on the chest and get the patient all ready for the team when they arrive. So that would be within nursing, is to put in on the pads on their chest.
And also to make the recommendation. Are we thinking we're going to move to a shocking the patient, right? Are we thinking we're going to move to a cardioversion? That recommendation can be helpful in the moment. And it's important to learn how to communicate that, effectively. Oh, is this, no. So she asked a good question, Leslie. Is this just for SVT?
Any fast rhythm where the patient is unstable.
Right.
So that could be regular, fast, narrow, complex rhythm, could be a fast, irregular, narrow, complex, or it could be a wide, complex, fast rhythm. So if I said SVT, which is an umbrella term for fast rhythms that are narrow QRS, so coming from high up in the conduction, not generally the SA node, but a little bit lower in the atria, it could be irregular. Fast, irregular rhythm, like an atrial fibrillation. They can be up to 100 or 180, 200. They can be a very fast ventricular rate, or it can be ventricular tachycardia, wide complex tachycardia with a fast rate. So you would use synchronized cardioversion for all of those.
Sarah's asked a really good question, Leslie. What's the difference between cardioversion and defibrillation?
Do you want me to take it? Do you want me to take a stab at it?
Yeah, take it away.
Okay. So remember that defibrillation is just the application of energy to a patient who has a shockable rhythm. So this is a patient that is essentially dead, and you need to apply large doses of energy to shock that rhythm, so to allow the SA node to take over. So that would be a shockable rhythm would be pulseless ventricular tachycardia or V-Fib. Those are the only two shockable rhythms, which makes sense. That's why our AEDs work, because that's all they're looking for. They're programmed to look for those two rhythms. So those are the shockable rhythms that you would defibrillate. It's an application of high energy levels, high joules, high energy to depolarize all of the myocardium to allow the SA node to take over. With synchronized,
so I'm just gonna repeat that again. It's V-Fib, ventricular fibrillation, and one kind of VTAC, pulseless VTAC. All right? We don't ever shock a patient when we've got a pulse. okay? And carry on, Leslie.
And then with synchronized cardioversion, and I always recommend that you would say to yourself, synchronized cardioversion, because it is critical that you hit the sync button. So on the defibrillator, there's a little button that says sync, because you're synchronizing the delivery of the energy to the downslope of the R wave. So this is going to be complicated. You are synchronizing the delivery of the energy to the downslope of the R wave.
The machine don't have to do that. The machine does.
No, the important part is that you have to hit the sync button. And I've got videos of, so it tracks the R wave and then it will actually deliver the energy at this. Why is that? Why would it matter that it just didn't like hit it anywhere? Why is it so critical that it goes, goes on the downslope of the R wave? Just think about it for a minute. Why is it so important that it delivers it onto the downslope of the R wave and say like not on the T wave?
As it's already expended that energy and it's trying to depolarize again. So you want that all the electrons to rush in to almost refill it.
Well,
a weird way to think of it.
You're almost there. So
Yeah.
when you deliver the energy on the downslope of the R wave, it keeps it away from that very vulnerable period on the T wave. Because remember that absolute refractory period, did you talk about that in A&P? The absolute refractory period from the downslope of the Q wave to the midline of the T wave. That is the absolute refractory period. So no impulse would really generate, but if you hit it with a really strong impulse on the downslope of the T wave, that can set up like a V-fib, a lethal rhythm. So you want to keep that energy away from that T wave. That's what you're trying to protect, because you don't want to have a worsening rhythm. So when you deliver it, it's going to track the R wave and deliver it on the downslope of the R wave so that it doesn't hit it on the T wave, that vulnerable period of the T wave.
So it's like you have a little safe zone. There's a little safe zone within that PQRST, that little safe zone to apply electricity that will not have an impact on creating other kinds of dysrhythmias, right? That can be very catastrophic. So that little safe zone, you don't have to measure that. You don't have to do anything about that, but you have to know that whenever a patient has a pulse, we are doing synchronized cardioversion, right? Synchronized cardioversion. And you'll often hear it just called cardioversion. Leslie and I are really advocating that you always in your head think synchronized. And that means that you press the sync button and then the machine knows it can only deliver that shock in the safe zone. Okay.
And and it's the way the technology works. And when you do your ACLS or et cetera, you'll know how it works. But if you did not initiate the sync button, it would defibrillate the heart. So that's why we always advocate that you say, remind yourself, synchronized cardioversion, to hit the sync button, because it's all the same steps, that you would do for defibrillation. The only thing is that you have a heartbeat that is perfusing, too fast, mind you. So you want to synchronize it to deliver that energy to slow it down, to allow the SA node to take over.
Okay. So again, here's just the bottom point. I don't want anyone to get lost or nervous here. And I apologize if that doesn't sound nice to you, but the only two rhythms that you're going to defibrillate are ventricular fibrillation and pulseless VTAC. Every other rhythm that you're going to apply electricity to, you're going to do synchronized cardioversion, and you're going to press that sync button. And if you are in a position where you are, let's say you have ACLS, you're somewhere in the United States, nurses would run their own codes in the ER until the physician got there. So we would be doing all of that. You are very clear in communicating that this is a synchronized cardioversion, and you're clear in communicating that the sync button is pushed. This is synchronized. If you're a nurse here working in a code, you're going to make sure that that is communicated effectively, right? If you're the one who's going to be involved in that, that this is a real point of danger for the patient.
So, and I think that sort of, we don't want to get too far, down in the weeds about how to do it, but I think that Sarah was just asking.
I'm going to give you a gift certificate. We'll give you a gift certificate for time in the lab when we're all back on campus for this, to be able to be able to push the buttons, okay?
Yeah, so we'll do the difference between synchronized cardioversion and defibrillation. Now, Hannah's asked a really good question about the use of adenosine. Oh, we used to use a lot of adenosine. I mean, we still do use a lot of adenosine. Adenosine is really only effective for narrow, complex, fast rhythms that are regular. Narrow, complex, fast rhythms that are regular. So it is not used for irregular rhythms. So I'm thinking atrial fibrillation, a fast A-Fib, we would not use adenosine for. And I'm going to just leave it at that it is used for a narrow, complex, regular rhythm. And I want everybody to plug their ears here because I want to just clarify this too. You'll see that with a wide complex, you can give it, but we're discouraging practitioners at our level. So for our purposes, it's a narrow, complex, regular rhythm that you would give adenosine to. But remember that we only give drugs, pharmacological interventions, to those stable patients. So this is a stable patient who has a blood pressure of 120, 130, and the heart rate is maybe 210. It's a regular rhythm. And the patient is not symptomatic. So you would use adenosine. And if I could just, I'm going to jump in here and just say that adenosine is a type of medication. It is a nodal blocker. It stops the SA or the AV node. And so when you give adenosine, the nursing responsibilities are that you prepare the patient. You need to tell the patient that they're going to feel flushed or they're going to feel funny feeling. Now,
pending doom.
Pending doom. Now, I'm going to just jump in here and say that sometimes my colleagues in emerge say, you're going to see the white light, but don't go near it. Because, and I don't recommend you say that, but what it does is it stops their heart. And so when it's given, I see screens and screens and screens, probably 3 screens of asystole. And the patients feel that. And so then it's very short-lived. That's the thing. The half-life is 20 seconds, so it's very fast. So you have to prepare the patient to say that they're going to feel impending doom, they're going to feel flushed, that they're going to feel a little bit different, but it's only a very short moment that we're right with them. And now,
I was also going to say, Leslie, sometimes patients will jerk or reach out or something. So often it's helpful if there's somebody there who might have their hand on the patient, because in that moment they can just flail out a bit.
And the other thing is, with adenosine is that if you are administering it, and a nurse would not do that without the physician being right there. Most hospitals don't, it's not something that a nurse would give, it would be the physician, but you might be having to act there to give it as extension of the physician's hands, I guess is the terminology. But if you had to give it, or you're supervising a new resident giving it, it has to be given very fast. So what we would do is we would have it at the closest port to the patient. You would have your adenosine drawn up. You would have your saline flush. You'd give the adenosine as fast as you could, if not faster. Then you'd flush it in with normal saline. Because if you don't give it within 2 seconds, it's not going to work. So you give a dose, a small dose, and then you would follow it up with a larger dose. So that is adenosine. Now I see some other questions.
Before you go on, and everybody will keep recording. Do you mind if we take a few more minutes just to carry on? Can I tell you a story about, and this I think about adenosine? Yes, it would be easier if they didn't all start with A, wouldn't it? Because they're also going to ask about some other drugs. Adenosine is, and it's characteristically, we often just really associate adenosine with an SVT, that supraventricular tachycardia, a narrow, complex, rapid rhythm. And I'm just going to tell you a story that exemplifies how you're differentiating between stable and unstable, okay? Stable and unstable. When I worked in the United States, contrary to what you see most often in Canada, nurses did give adenosine. That was part of our responsibility. And I had a young patient who came in who was pregnant. She was, I think she was about 28 or 30 weeks pregnant. So she was fairly far along in her pregnancy. And she came in with first-time episode of SVT. Her heart rate was about 160. Her blood pressure was 122 on like 75. O2 sat was fine. Did I apply oxygen? Yes. The other reason I applied oxygen in this situation is who else am I giving oxygen to? The baby. Now, this is not related to this, but I'm going to tell you one thing. People always get worried about babies in situations like this. Save the mom, save the baby. Okay, so we're not thinking C-sections and other things, even in traumas. We're thinking save the mom, save the baby. So we always just focus on the mom. But I did also check fetal heart rate, right? Because I need to know she's okay, baby's okay. And so she is, she's got a heart rate, what did I say? Let's say 160, and she's got a blood pressure, I think, I don't know, 120 on 80. Let's just say that, 120 on 80. Is she stable or unstable? Stable, unstable. 120 on 80. What's that blood pressure like to you?
Normal.
Fine. So she's stable, right? Stable. That makes a big difference. So if she was unstable, we move to electricity. Do we apply electricity to someone who's pregnant? Save the mom, save the baby, right? Anyone who is unstable. Unstable means that this is a precarious situation and they may die. So it's not going to help the baby if we let the mom die. But she's stable. So we're going down a different pathway. And what did we say might be a first response, first treatment for someone who's stable? She's got that good blood pressure. We've got some oxygen on her. We talked about this. What might we ask her to do? Yeah.
Bear down.
Yeah. Do a vagal maneuver and do it a couple of times. You don't just get to do it once and then it's over, right? Do it a couple of times. See if you have any success. No success. I did oh my, of course, oxygen monitor IV. So she's got IV access. Even if I'm not about to give a medication, I would have that IV on before we started the vagal maneuvers, right? I like that IV you get that on in 1 minute. And if you can't get that IV started in a minute, I need another nurse there. I need another pair of hands, okay? And so we've got that. And the doctor came over and assessed her and said, okay, go ahead and give the adenosine. And now I had been able to look up in advance adenosine in pregnancy. Now she's stable. Would I be thinking differently if she was unstable? I might be. I'd still look it up though, wouldn't I? Like if it was absolutely contraindicated in pregnancy, then it's absolutely contraindicated, right? But she's stable. And what it said was there's not enough information to know about giving it during pregnancy. Lots of drugs, there's not enough because we just don't regularly give them, right? We haven't done studies. Not enough information to know if this drug was safe in pregnancy. So he said, go ahead and give the adenosine. I said, it's a category. I can't remember what category that is, C, whatever. It's a category C drug. And he said, that's fine. Go ahead and give the adenosine. And I said, I'm not able to give the adenosine because she's stable and it's a category C. And then he looked at me, we're talking right at the bedside, and he said, go ahead and give the adenosine. And so I had to say to the patient, I'm sorry, we're just discussing a medication, not to worry, you're just to make sure she gets, this is not a fight. We're both very calm. I can't say, let's take this out of here because I actually don't want to leave her, right? It would be nice if there was other people to say, let's take this out of here. So I said, I repeat again, I am not able to give that medication because she is stable and this is a category C drug. If you want to give that medication, then you can get it from the Pyxis machine is right there. And I know you know how to get medications out, right? So he can give it. I can't stop his practice, right? I can't stop his practice. He can give it. And then he just angrily, now remember, she's stable, right? She's not sweating and she doesn't have chest pain. We're watching all of this. I don't want to leave her in an SVT, but I don't know. Do you see how I don't have enough knowledge to know if this is adequate? My resource tells me nobody has enough information. So he angrily said, fine, call cardiology. So we called for a cardiology consult and the cardiologist calls right back and asked, is the patient stable? Patient was stable and cardiology said, I worked at both at shock trauma and at a community hospital, two opposite ends. This was at the community hospital that did not have a labor and delivery floor. She was about 30 weeks pregnant. The cardiologist said to transfer her to a hospital with a labor and delivery floor, have medications ready en route should anything change, but hold the adenosine until we know better, until we know what's going on. And he would meet her at the other hospital. He worked elsewhere at the other hospital. Do you see the point? Like just because someone says give it, just because it might be indicated, There might be certain situations where it's not. And that line of stable or unstable is a really critical line in your thinking. Does that make sense to you?
And with SVT, don't many episodes spontaneously resolve? Like, how do you know when you hit the point that, like, I've had a friend, almost actually same situation. I made her go to the hospital because it was prolonged for like 4 hours, but often she would
even go right away.
2 hours, she'd kind of hang on and then they would stop, or she'd do vagal maneuvers at home. And, but how bad do you know when you need to be?
You should, like, and that's yeah, it's great, Jen. So first of all, we're going to look at the patient situation. You would only give the adenosine if the patient is in the SVT at that point, and that medication is required to break that rhythm. But if someone is at home and they go into a tachyrhythm, they should go and be seen, because they may need an antiarrhythmic or some medication, because she kept going back into it, and that's taxing. That's very taxing for the heart. Even if someone had one episode of a very fast rhythm, like above 150, but it resolved, then my own personal recommendation was go be seen, right? Because just because you've had this very fast episode of a rhythm and now it's stopped at home, but it's a fast rhythm, like 150, let's say that was my mother, I would take her to the hospital, because my concern is it may be resolved, but I don't know what caused that. And I don't know that it's not going to recur. And the next time might be more lethal. So even though she was I would have actually just said, go. Like, we're going to go, we're going to check it out. Is this an electrolyte problem? Is this a conduction? Like, is something happening? And also, they have the opportunity to get a tracing when she's having that. And that's really critical for diagnosis. Even for diagnosis, that's so important, right? So I would say, and so is there a point where you say adenosine, no adenosine? If somebody is in an SVT or like that very rapid neurocomplex, they wouldn't leave somebody in that rhythm. So they would, if you were at like 118, they're probably not going to give you the adenosine, but they may watch it and see if it comes down. But they're going to treat the rhythm because of the burden it places on the heart. And remember, we're always thinking, what's happening next?
So the same person since then, she's since had an ablation and had it fixed, but she was just diagnosed with, like, you have SVT, so you'll flip in and out of episodes until you have it dealt with.
Oh, okay. So she did have some background that told her.
Yeah, but it was still just like, if this were to happen to someone for the first time, being a bit medication averse myself, is this something that you say, well, maybe I would prefer to personally wait it out a bit? Or
no.
It's something that is standard practice.
Yeah. So, and Leslie, you may say something else, but the burden that a rapid rhythm places on your heart, and you don't know that how long this may last, that this rhythm may last, and or it may move into a rhythm that is even more lethal, right? So sometimes it self resolves, and sometimes it doesn't. But even if it resolves, you may go back into that very quickly, and your heart hasn't had time to recover, and or that real burden of increased cardiac output at the same time as increased cardiac demand and decreased oxygen to the heart cannot be understated. Right. So I think for me, it's always, the recommendation is always that you be seen, you be monitored. If at the hospital, there's a common team decision, let's wait this out, let's see what happens, let's do other things, that's one thing. But at home, I would never recommend that somebody stay at home and wait it out, because we don't have enough information. And we don't even know what it looks like. You don't know at home, let's say somebody's having a rapid rhythm, you don't know that's not because they're having an MI and they've gone into a rapid rhythm, because we don't see the tracing, right? You don't know, we would never assume based on someone's pulse what that rhythm is. Never, never, never. So
I suppose I definitely think they should be seen immediately, go to hospital.
Right.
I feel worried that every hospital doesn't have a Sue Coffey nurse there to advocate.
They do, honestly, like, look, oh my gosh, they do. This is what, and you are all those nurses. You are all those nurses who are thinking your way through this, right? Who are thinking your way through this. And I would just say the critical care physicians really are exceptional. They are just very exceptional. And if you ever find a place, most likely where you work without hierarchy, I would say it's the emergency department. I would say many ICUs, surgical ICUs, CV ICUs, you see that as well, but also there are some older physicians in particular where there might be a little bit of hierarchy just left in some of those situations, Leslie.
Even younger.
Yes.
This is, I am the expert in this field. In fact, I saw you know, who is that very famous one from UHN? The Brazilian cardiac surgeon. You can see the sparkle dust just around it, like he had electrical field around him. He brought his own nurses. He brought his own nurses wherever he went. Yeah. So, but yes, and I'm going to say that the big thing with these fast rhythms that I'm concerned about, especially at faster rates, is clot formation. Yeah. That's really what I'm worried about when they keep flipping in and out. Now, it's not as much of it. You still get some, you still get atrial kick with a regular rhythm, but albeit it's going so fast, you're missing a lot of it because it's going so fast. So I'm always worried about clot formation.
And the other thing, before I forget, I just want to say one thing, and then I want to answer these questions about other drugs, because you know, SVT is just one kind of rhythm, or a rapid, narrow, complex, regular rhythm is what we've been talking about. Is that one of the fast rhythms that we may see as a narrow, complex, rapid rhythm? Leslie mentioned as an irregular rhythm, atrial fibrillation, but also atrial flutter. And the one thing about atrial flutter that when we talk about all of those P to P, R to R, and other things, atrial flutter, it's so, so important that we measure the atrial rate and the ventricular rate. In most rhythms, we see one P wave before one QRS. In atrial fibrillation, we don't see any P waves because it's all just that fibrillation. In atrial flutter, we see those rapid sawtooth waves, right? In atrial flutter. And you can't just count. This is the mistake many people make by saying, because we want to say, what's the ratio? Are there 3 P waves to every QRS? Are there 2 P waves to every QRS? We want to know that ratio, right? You can't just count how many I see. Do I see 2 sawtooth waves and then a QRS and then 2 more sawtooths? Because that flutter wave and the T wave can become very mixed up. And so what you really have to do, this is really important, is not only measure the rate, R to R to R to R for your ventricular rate, you need to measure the rate P to P between those 2 sawtooths. And so if your ventricular rate is 75 and your P to P rate between those first two sawtooths is
300,
then you've got a 4-to-1 ratio, right? You have a 4-to-1 ratio. Does that make sense? You're not just counting them. I might only see 3, but it's actually 4. So the only way you determine the ratio is to count the rate. And you do that by measuring P to P, that individual P to P. Does that make sense, guys? It's so in that.
Could you explain that again? I'm still kind of confused.
Okay. Atrial flutter, as opposed to atrial fibrillation. Atrial fibrillation, we have no discernible P waves. We just have that fibrillation, right? Of the P's, no P waves, and we would document that, no P's, and we'd measure, we'd look at our QRSs. Are they, what is the width of them? How are they narrow enough? And also we would do our rate by the 6-second rule because atrial fibrillation is irregular. But atrial flutter, it is quite an elegant analysis, I think. For me, it's just one of my favorite rhythms. Don't you think, Leslie? It's just really. To me,
it's how regular that the atria keeps going around, and so it's always the same rate of conduction. And I just don't even know how the heart would know that. How does the AV know to let every fourth beat through? I just think that's so interesting.
Yeah, me too. I do love it, and I also think it requires it is a sophisticated response from you. So you're going to go through your whole analysis again. And we're going to come back to the P. We measure P to P, right? Is that how we start with our, when we do our systematic approach? P to P. Now in atrial flutter, I have a lot of P's because I have multiple P waves happening before whichever one, the second one, the third one, the fourth one, intermittently that P, the depolarization is allowed through that AV node. All right, so is there a P wave preceding every QRS? There is. We can measure, it is a regular rhythm, and we can measure the R to R interval to get the ventricular rate. But to get the atrial rate, I need to measure P to P. The problem here, or what's different here, is that it's not just a P wave preceding a QRS. I don't measure from the P wave preceding a QRS to the P wave preceding the next QRS. I measure from one P wave to the next P wave. right? Usually that's from one preceding a QRS to one preceding the next QRS. In atrial flutter, one P wave is followed by another P wave, maybe followed by another before we get to the QRS. So to measure the atrial rate, I have to measure from one P wave right to the next one beside it. And there is an example in the workbook, and we'll make sure that those correct answers are posted. And so then I look at the rates. If my ventricular rate is 60, but my atrial rate, P, when I measure that, is 180, or roughly, let's say it's 170, because you're always going to have little bits. So then I'd say it's a 3-to-1 ratio. It's going to be a whole number because it's that intermittent passage through the AV node. So with atrial flutter, I not only want to say what the ventricular rate is, I want to say what the atrial rate is and what that ratio. Is it a 2-to-1, 2 depolarizations of the atria for every depolarization of the ventricle? Is it a 3-to-1 ratio? Is it a 4-to-1? I've never you seen beyond 4-to-1, Leslie?
Yeah.
Oh, no, I've never seen that. And so often they call that sawtooth. It looks like a sawtooth. Someone asked a really great question. What's the main difference between A-flutter and A-fib? So in atrial fibrillation, the atria is not even working at all. Like, so there is no organized conduction through the atria, and there's no organized contraction. So you have it fibrillating. And because of that, we're losing that 30% of atrial kick, percent cardiac output. And we're also at risk for those clot formation. And remember we said with that the new evidence that's coming about almost all the clots form right in the peak there, like sort of the triangle top of that atria, that typically to date we have moved to anticoagulation for patients who are in chronic A-fib, and now they're moving to another potential treatment, which is this Watchman procedure. Not available yet in Canada, as far as I know, but becoming more and more common in the United States. And that means patients don't have to be, they have an umbrella put so that blood does not flow to that part of the atrium. And so it's not likely to form clots, and they don't have to be on anticoagulants. So a fascinating new approach, and we'll watch it and we'll see if it becomes approved as a therapeutic in Canada, a therapeutic treatment. So in the atria, you've got that fibrillation, no good, the conduction is just sort of random in that atrium. There's not any good coordinated contraction, and you lose that 30% atrial kick. You also then have an irregular rhythm, right? So an irregular rhythm. In atrial flutter, you see a regular rhythm. What's happening is that that conduction is being initiated in the atrium. It's getting down to the AV node, but the AV node is saying you're too soon, right? Like, no, I'm not letting you through. Then another one starts and it says, no, I'm not letting you through. And let's say the third one starts and it says, okay, fine, you go through. And so it becomes a pattern, a regular pattern, where that initiation of the conduction, a very rapid initiation of conduction in the atrium, moves down to the AV node and is intermittently blocked. And it's intermittently blocked in a very regular pattern, either 2-to-1, every other conduction process is blocked, and we wait for the next one to come down. 3-to-1, one goes down, the AV node says no, another one comes down quickly, AV node says no, another one comes down, AV node says fine, go through. So you have that conduction that is blocked at the AV node. And so what you see, because that conduction starts, you do see the P waves. You see those P waves as that conduction moves through the atrium, right? As it moves down through the atrium. But what you don't see is then that movement to a QRS, because the AV node does not let that conduction carry down through the ventricles. So atrial flutter, it's not a sustained rhythm. So I don't know, Leslie, how long is the longest you've seen someone be in atrial flutter without, not to the point of treatment, but without treatment?
Oh, I was gonna say most people that I've seen in atrial flutter have been unstable, so we've treated them right away. Atrial flutter, I wouldn't say. Atrial fibrillation is so common, so very common, whereas atrial flutter is not as common.
I've seen people who are stable at the moment. You're always moving to treat atrial flutter. And again, you're looking at other things. So again, blood pressure. And when you're looking at a patient stable or unstable, one point I want to make that I haven't made well enough, I think, is you're always asking about chest pain. Are they having any chest pain? Because even if they have a stable blood pressure, but they're having chest pain, that may influence the kind of treatment you're going to, how aggressively you may treat something. So atrial flutter, we're going to treat, it's not a sustained rhythm. It's not like you can't stay, A-Fib you can be in for the rest of your life. Atrial flutter is not like that. You don't stay in atrial flutter for sustained periods of time. That's, I do have to say, it is a little bit of a, I have a little sweet spot for it because you don't see it all that often, because it's so elegant on a strip, because we do this extra analysis to understand the ratio, because it represents something fascinating about how our heart, again, is part of a rescue system, right? How our heart blocks some of those conductions so that we don't end up, if everyone was conducted through, we'd be in a VTAC, right? It's so fast. The atria is firing so fast, we'd be in it. So it's a little bit of a heart saving us again, like the redundancy saving us again. So I do love it, but it's not sustained, and we're going to treat that. So the difference is whether it's regular or irregular, how well a patient is able to tolerate it. We know A-Fib, it's not ideal, but many patients tolerate it for a long period of time. What else should I say?
So with atrial flutter, the ventricular rate could be normal, and then the atrial rate is going to be increased, most likely.
Yes, that's what you're going to see. So because the atrium is conducting that depolarization at a fast rate, typically 2 times, 3 times, 4 times, let's say even 5. I probably have only seen it.
I think the atria, isn't it 200 to 300 is the actual atrial rate for atrial flutter, where the ventricular rate is normal.
So you're going to see, and it's going to be regular. You're going to see that regular ventricular rate and narrow complex, but you've got all these, and so it looks like a sawtooth between the 2 QRSs. It just looks like if you imagine, just like that, up and down, regular. It doesn't look like A-Fib where it's all irregular little bits and pieces. It's up and down, up and down, up and down, just like a sawtooth. And it will be very fast.
And an atrial fib, it's just quivering, as you said, like that. There's so many ectopic foci in that atria, all just firing. It's up to like 400 per minute, if you can even imagine. I can't even imagine. That's not even what I can think of.
I can't really count anything. So in atrial fib, when we're looking at the P to P, there is no P to P. Atrial fib, there's no P to P. We're not worrying about that, right? Atrial flutter, we are counting that, and we're doing the 2 Ps side by side. You've got examples, and for sure you have a lecture on that too.
And what about the question about the difference between those other A drugs? And trust me, everybody gets all mixed up with those A drugs for sure. So atropine is a vagolytic. It cuts the vagus nerve to allow the SA node to take over at the usual rate. So atropine is a vagolytic, cuts the vagus nerve so that it increases the heart rate by allowing the sympathetic to take over. Amiodarone is an antiarrhythmic. And I don't think it matters what class. It's an antiarrhythmic, and it works very well for wide complex tachycardia. So for instance, ventricular tachycardia. You know that ventricular tachycardia can present with a pulse and stable, with a pulsar unstable, or pulseless. So amiodarone can be given for all of those presentations. So amiodarone would be given in a mini bag over 10 minutes for the patient that's stable. And for the patient that is pulseless, it's given as a 300 milligram IV bolus. So amiodarone works so well with atrial arrhythmias as well. That's why I think it's such a versatile drug. That's the drug we used to give for all of our fast atrial fibs in cardiac surgery. We would just have them all on amiodarone infusions because it works so well on both atrial rhythms and ventricular rhythms. So that's the difference between atropine amiodarone, and you know about adenosine. Any other questions about the drugs? Okay.
And again, I'm going to say, remember, this test is not about memorizing. And the first day you're working in the ICU or the ER, I would never think that you would have all of this memorized. I would think that you would work your way through it. And for me, it's always about understanding. If I understand the action of the drug, if I understand what's happening with the patient, as opposed to just memorizing things, then you're more likely to be able to sort of puzzle your way through, what do I need? In this situation, I need an antiarrhythmic, and I need an antiarrhythmic that's going to decrease excitability or whatever. And so for the test, you for sure, if you're just going to have everything and you're going to be flipping back and forth from PowerPoints, that might take you longer than you need to know. You might want to make, again, it's old fashioned thinking, but I just think to have something ready, you might make like cue cards, or you might make a something. In future, you might have your phone and practice looking things up, like looking up your drugs or looking up other things to be ready. But you're not going to have to, you're going to need to understand. And I think that's the difference between people who did really well on the first midterm. Almost everybody did really well, and those who did exceptionally well is really that, I think, that level of understanding. And this test is going to be the same in that sense. Do you understand what's happening? Can you explain what's happening, even to yourself, so that would tell you to say, what's the first step I need to know? What do I need? What more information do I need to know? So what assessments could I do? What actions need to be taken? And even if the action is not by you, so differentiate in your mind between what I need to do and what someone else might need to do, where in which case I'm making a recommendation. So for example, if a patient is unstable, let's say they're in an SVT and they're unstable, and I'm thinking I need to tell the doctor, go give adenosine. Well, actually, if they're unstable, they'd probably be getting a shot. Anyways, let's say they're stable, but it's very rapid. And then the doctor comes in and says, where's the IV? Because I haven't done my part. Like, what is within your domain? Don't be getting so caught up in, is this a synced cardioversion? You need to know it. You need to know it because you are also responsible as a team member in that room. You are absolutely responsible for patient safety. Oh, look, Amanda has somebody who loves her. Sorry I hope I didn't embarrass you, Amanda. And I'm sure I did. Sorry if that's inappropriate. I apologize. But you need to also know your role, right? So when Leslie talks about, oh my, that is your role. So don't get ahead of yourself about, do we need this? Do we need that? If you don't have an IV in a patient who is unstable, get the IV in, right? Think of that as life access. And if you can't get the IV, get someone in to do that. So I think in this course, we try to move beyond that idea of getting help in general, but I need help for this, because that helps you to really understand what are the actions that need to be taken. And every one of you will be the leader in the moment, right? A leader in the moment by being able to think your way through it. But you're never going to get on the test like something like the mega code so fast, tick, 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 tick. You'll have time to work your way through. Another exciting thing about, I think, this midterm test is we're going to try a new model of question based on the upcoming changes to the NCLEX, where you have a case study, a sort of a situation, and then you have it unfolding or evolving. And that, again, is hoping to help you prepare even further for what the NCLEX may look like. Okay, any other questions? Any questions? How are you guys feeling? Was this helpful or not helpful? I worry that we're talking too much. Mostly we just love it. Leslie and I would pay to have an opportunity to talk about it. So
I was just going to say how much I love this. I love being part of this Friday morning sort of drop in, and I hope I don't talk too much, but yeah, I love it.
I know. Don't you wish, honestly, sometimes I just wish that somebody would like have a heart attack right in front of me, and then I could just do what I need to do, because there's nothing so exciting.
Yes. And so yes, thank you so much for allowing me to be part of your Friday mornings. This is a lot of fun.
Now, Kayla said it's been hard not to ask too many questions. Do you have questions, Kayla? Did we answer them as we went along? Because please just jump in. Like, we really, for us, this is fun.
We love the questions because we can talk all day about this. Yeah. We need your questions to help us focus, or else we need
to know what you're getting and what you're not getting. So anything, if you have questions, just type them in there. That's the whole goal. Because if you have it, I'm sure a million people have that same question. And this is recorded for those who aren't here as well. So
no, I think I always ask so many questions during a class time. I've found it very hard just watching a lecture and then just having all these questions and nowhere to ask them.
I know, right? And so it is fun here because we get to, your thinking propels us to answer things in a way that we hope clarifies or takes it like one little step further or something like that. And it's a little bit more anecdotal, right? It allows us to have, to give stories and a little bit that help us to make things, I think, come alive a little bit more and be, and be representative of the real world. And also to differentiate with you between what you're going to see in a textbook and what Leslie and I are going to say about the real world. And I think that's so critically important. Takeaways, you know how to use that systematic approach. You may work, let's say you go and do your practicum in the ER and somebody says, oh, really, you're doing it? Like, I don't even remember all those things. That's because they've absorbed it so well. You need to do the systematic approach. You cannot get to the right diagnosis without a systematic approach. Sometimes nurses say, because we're not allowed to make a medical diagnosis, are we allowed to say what that strip is? Can I say that's a, I don't know, atrial fibrillation? Can I call something atrial flutter at a 3-to-1 ratio at a rate of 75? Yes, that's not making a medical diagnosis. That's like saying the blood pressure is 80/70. That's not a medical diagnosis. That's the evidence. You're just doing an analysis of the evidence, right? So you call it what it is. But before you ever call it, don't ever jump to calling it what it is before you've done that systematic approach. And it becomes ingrained and so fast that you do it without thinking. So for sure, you're going to do that systematic approach. You're going to, just some tidbits that are coming to mind. You're always going to ask that question, stable or unstable? Stable, I have a lot more time to do a lot more assessment. Unstable, I'm moving very rapidly to treatment. Leslie talked about patients who are unstable. We're going to move to use of electricity much more quickly, right? We're going to move to patients who are unstable, who have rapid rhythm and unstable. What are we going to do? 2 words.
Synchronized cardioversion.
Always synchronized, right? Always, we're going to think synchronized because we are in our heads going to always be saying, I'm the last check. I don't even know if I'm that person. I'm the last check to see that that sync button is pushed, right?
Sue, can I just talk about electrical for slow rhythms, or
Yes.
are you not there?
Could you just say something about that? I really want
to. So as we talked about, if it's an unstable rhythm, if it's fast, it's synchronized cardioversion, but if it's slow, we would initiate a pacing. And all of the equipment that we use will have pacing functions. So that if the heart rate is too slow, we would actually put on external pads on the chest again, same pads, and we would initiate transcutaneous pacing. And again, application of energy is not within the nurse's role, and some nurses are specially certified because this is an emergency situation, because we only pace somebody who is deteriorating. So if the heart rate is too slow and the patient is symptomatic, and what is unstable, and how do we define unstable again?
Based on like their blood pressure and if they're having chest pain.
So that they have hypotension, experiencing chest pain, that they're short of breath, or an alteration level of consciousness. Those are the criteria for determining if the patient is unstable. Then you would initiate transcutaneous pacing.
Okay, I did have a question about that because it was in the sim and I was going to ask about it when you guys were talking about defibrillation, but that answers my question. So,
okay.
Thank you.
And do remember that if you have your patient is being paced, that's transcutaneous pacing is a temporary measure till cardiology gets there and makes some more, puts in a temporary wire or that sort of thing. But this is just a temporary measure to buy time to actually provide that stimulus to the heart.
So simply, sorry, it's just like delivering like a regular rhythm without like delivering that shock, right?
It's delivering energy to the heart to initiate the the conduction pathway. Because remember, we've got electrical and mechanical. So this is initiating the electrical. It's sort of flogging the SA node. It's not actually the SA node, but it's actually flogging the heart to initiate that conduction for depolarization.
Okay.
So it's an artificial stimulus.
I'm going to jump here just for a second, only because this is so important. I want, again, a thing I want you to carry around in the front of your brain, not that you have to retrieve or look on a paper. Do not shock a bradycardia, right? So we don't shock a really slow rhythm. But
All rhythms.
Well, what?
There's only the two rhythms that you would shock.
Right. When they're pulseless, right? When they're pulseless, right? So it's like the patient's dead. Remember, there's that V-fib or a pulseless VTAC. They're pulseless. But if we've got a pulse and we have a rapid rhythm, application of energy would be that synchronized cardioversion. Rapid rhythm, synchronized cardioversion. A bradycardia, a slow rhythm that is making a patient unstable. So it's a slow rhythm that I can't just give some medication like our medication to bring up that heart rate. Application of energy for that bradycardia that's leading to an unstable patient takes the form of external pacing. And that's buying you time. And so what you do is the same pads that you would use to defibrillate a patient, the same pads that are used for synchronized cardioversion are the same pads that can be used for pacing, right? Same pads. And what will happen is, so there's not like a rate, like you can say, okay, this is, you know how we have typically standard joules that we may set our a defibrillator for when we're providing either synchronized cardioversion or defibrillation. For pacing, unless you correct me, for pacing, we start at a low rate, electrical rate, and we bring it up and we set the rate. I want this to be a heart rate of 70, let's say. We set that rate, and I bring the energy up, and I'll start to see a pacer spike. Do you know what a pacemaker spike looks like on a screen? It's just like a line, like a little line. And we can see that's the electrical line when we are providing that little bit of electricity. And we bring it up, we bring up that electricity slowly until we see that there is capture. And that means after that electricity has been provided, we see that depolarization happen, that conduction happens. Yep.
This was one of my questions. I've watched on YouTube how people use these machines, and the same machine, as you said, can have different settings for whether you're shocking or whether you're doing sync or whether, so is this a standard machine in every hospital? Because it feels like you need to work for NASA to learn all of these pumps and machines that we have to do. And also, as you had said, the nurse in these demos that I've watched, they all are just like, we're just gonna kind of start at 2 or whatever, and they're just like titrating to what's needed. How are we supposed to know what to start at?
I don't know. Leslie, do you want to jump in? Do you want me to?
So first of all, you're not going to be in a position the first week off, that you graduate, that you're going to be titrating someone's pacemaker. So you're going to be orientated and you're going to be supervised. And again, application of our role is to actually make sure that the pacing pads are on. And remember all those principles that you've learned in BLS, same principles. So you've got that down pat. It will be up to the medical personnel to come in and titrate it. We don't actually titrate it. I guess an emergency would. Sue, did you do it in emergency? You put on the pacers? No. Yeah,
I put on the pacer pads in the United States. I did it myself. Again, where you have a different role. In Canada, I did not in Canada here in the emergency department where I worked, even with ACLS training. You know the process. You know the expectation that you're slowly increasing that energy until you have what's called capture, and you'll see the complex then follow. Right? You'll see the complex, and you've got capture. Don't get in this too deep, but you need to be aware of it. That if a patient is unstable with unstable with a bradycardia, but has a pulse, we don't ever shock anybody with a pulse, right? We can do synced cardioversion with a rapid pulse, with a low pulse, and unstable. We're going to do application of energy in terms of external pacing until we get cardiology, either in like the ER to put in a temporary pacemaker or whatever. It could be, and then they move to having a permanent pacemaker. In any case, you don't need all of that. The only point I'm also going to make here is that it is painful. It's very painful. That external pacing is very painful. So once a patient is stabilized, so we've got that pacer on, and the patient, and so it's giving a beat, like that electrical energy. Let's say you set it for 70 beats a minute, 70 times they're getting a shock, right? A shock, which doesn't feel nice. A little mini taser every 70 times a minute. So if the patient's stable, the heart rate is stable, we've got a consent already to send them to the OR. We always have to be thinking before we sedate somebody, what's happening next. I'm not going to leave them in pain for an hour. But do I have an understanding what, in case the doc's going to go and put in a permanent pacer right away, as opposed to just a temporary pacer, depending on lots of things, we want to see sedation. Are they stable enough for some kind of sedation? Because it is very painful.
Or analgesic. We would always provide analgesic for somebody.
Sorry, yes. Yeah.
For transcutaneous pacing. So the nursing responsibility would be to know that TCP, transcutaneous pacing, is indicated. We want to get the medical personnel there, but you know, Jennifer, you might have a new resident on that night who's a little bit intimidated. So you're actually telling them, turn this button, turn that button. Although it is not within nursing's role, we still are part of the team. And that's what sometimes we have to do, is really coach other members. So you're going to, for a patient that is symptomatic, unstable, you would put on the transcutaneous pads, that's their job, and you would have TCP initiated. So that treatment would be transcutaneous pacing. You'd also want to monitor the patient's vital signs and provide analgesia as required. That would be sort of nursing's responsibility. You'd also want to understand what the rhythm would actually look like. And so as Sue was saying, it's that pacer spike followed by a wide QRS, because that means that's where it's being paced, and the T waves of the opposite direction. So that's how you know you've got a paced rhythm. It's the pacer spike that you're going to see. And so that's how, now I just want to make a really important point here, is that just because they have a heart rate of 40 doesn't mean that they automatically get treatment. This is for an unstable patient. And we've already defined what unstable looks like. I have seen patients, and I've discharged patients from the cath lab with a heart rate of 40 and a blood pressure of 130 on 80. And we sent them home. The reason being, that is their normal. Now, not everybody's Lance Armstrong. Lance Armstrong doesn't get his heart rate much up over 40. But for the rest of us, that might be a little bit low for us. But if they have an adequate blood pressure, that just means that we would treat them with a pharmacological agent if required. This patient's perfectly stable, doesn't need a thing. And they maybe that's their normal.
And when you work in cardiology, it's fascinating because there are patients who are sent home at 40 and even lower, because they're able to tolerate it very well. I had a patient once who came in with a heart rate in the low 20s. Now this is really so remarkable. Could not go home. This is not a go home, right? This is not a go home. But that patient was stable. Hard to believe, right? Hard to believe. Ranged between, like, I think around 22 to 26. And there was lots of time to look at treatment for that patient because the patient was very stable. Hard to imagine, isn't it? That was like a memorable situation for me. So it's a question you're always asking, is this patient stable or is this patient not stable? And do you remember the 4 criteria Leslie just mentioned to you? Can anybody remember them?
Blood pressure, loss of consciousness, I don't know, chest pains in there, maybe. And I forget the other one.
And shortness of breath.
Shortness of breath.
Okay.
Now, you may also see on, in an exam, or you may see a patient that is sweaty or feeling lightheaded. Those are symptoms that you're going to follow up on, but that wouldn't be the hard criteria to start pacing. They may be sweaty for other reasons or diaphoretic. So it's really those hardcore symptoms that would initiate the intervention. So if a patient is unstable, some kind of electrical intervention, synchronized cardioversion if it's too fast, pacing if it's too slow. If they're stable, and the reason why it was always hard for me to get my head wrapped, well, if they're stable, why do we need anything? Well, we don't want people that are not normally with a heart rate of 40 walking around with a heart rate of 40, or we don't want somebody that's a heart rate of 200 walking around with a heart rate of 200. So we have to try and normalize that rhythm and that rate. So that's why we would use a medication. We would use atropine for a slow rate. And I'm not going to get into the hardcore criteria with the atropine. Just for all intents and purposes, a slow rate gets atropine and a fast rate gets narrow complex. Regular rhythm would get adenosine. If it's an irregular rhythm, and we didn't talk about this, but if it's a regular rhythm such as atrial fib, you could give, and it's fast, and the patient's stable, you could give an amiodarone or a calcium channel blocker or metoprolol. Looks like Amanda has to sign off now.
Amanda, it was wonderful having you here, and say hi to your boyfriend from all of us, and my kids and my cats and everything else is going on in my house. So nobody ever needs to apologize with me. And I am always grateful for your tolerance as we're all working our way through the tail end, I hope, of COVID.
Thank you. Bye.
Bye.
Any other thoughts or questions? I think what I would say, sort of as we approach the test, is think your way through. Always think, don't get so caught up in, oh my God, what? Think your way through, right? Because a critical care nurse just thinks his or her way through a situation. Start with a very systematic approach, determine what's going on. Always be asking that question, stable, unstable, and what are the criteria that I'm applying to that? What is my role? What is someone else's role? And what is my role in assisting someone else to conduct their role? For example, make a recommendation, call and notify. When we have new information, another point I would make is when we have information, even if a patient is stable, and I think I saw this with the blood gases, even if a patient is stable, let's say compensating, but their blood gases were not within the normal range, we still report that. So if a patient's heart rhythm changes, even though they're perfectly stable, I still need to report that, right? I don't just go ahead and do things. I'm still reporting that, and I make a recommendation. That's why we're always doing not just IS-bar for reporting, it's IS-bar thinking. We're thinking as IS-bar. We don't have to do the introduction part, but going through that process really fast. What's the situation? What's the background? What's the assessment? What's the recommendation? So important, because that recommendation helps me to think, what do I need to be ready for? What do I need to do? And some of it may be independent nursing, right? Sitting the patient up, putting the patient down, whatever. But it is really important holding a medication until I determine, is that medication warranted given this change in something I'm seeing? So any final thoughts from you, Leslie?
No, I think it's just, oh my, stable or unstable.
Mm-hmm.
And then the systematic approach.
Systematic, yeah, absolutely, systematic approach. I hope that this is, I hope it's helpful. For sure, you're all gonna get like the IOU to have some time in the lab when you've got time, because it will be fun just to get your hands on those things, right? Leslie and I will show you how adenosine is given, that often it's two people, where one person's pushing, the other person's pushing, like rapid, right? And so it's really important that be given very fast. And we'll show you how to apply pads. We'll show you how to apply the electrodes for a 12-lead ECG. And we will show you how to set things up for external pacing, for synchronized cardioversion, and for defibrillation. Just so you feel like, it's not your responsibility, but it's nice to get your hands on things and feel confident.
Because you'll be watching, as I said, part of the team, you're going to get new residents. And you need to be able to guide them as well. I know it's hard to believe, but that's what we do. We're all part of the team.
It is hard, yes. Well, there you go. We are part of the team. Anything else from you before we sign off? Thanks. It was great.
Thank you for letting me join.
Oh my gosh. Well, no, Leslie, thank you for being here. And also just thank you to everybody for letting us take a little trip down memory lane, because it's always probably more fun for us than for you. And it's a real privilege to spend some time with you. Bye, guys. Have a great day. Have a great weekend. It's supposed to be nice and warm.